Hello, I'm Tanya Chamberlain from the Division of Anatomy at the University of Leeds, and in this video we will be exploring the act of mastication. So if you've ever wondered what muscles and joints allow us to talk to our friends, or spend chewing down on our lunches, then this lecture will help you understand those actions and how our body enables them. So let's get right to it. There are 4 muscles of mastication which we will dissect throughout this video, and 1 accessory muscle, which we will look at to understand how this assists in the opening and closing of our mouth. These muscles come in pairs, so there are 8 muscles of mastication in total and 2 accessory muscles. The first muscle is the Masseter, followed by Temporalis, followed by the Lateral Pterygoids, the Medial Pterygoids, and finally the Digastric muscle. We are also going to become familiar with this image of the TMJ, so let's have a brief overview of the bones and the anatomical landmarks that we will need to establish for the rest of this lecture. The 2 bones of the TMJ, as the name suggests, are the temporal bones of the skull and the mandible. These 2 bones come together at the mandibular fossa of the temporal bone under the condylar process of the mandible to form a joint which allows for the opening and closing of our mouths. We will come on to look at the movement of the mandible in a while, but for now let's have a quick look at the joint itself. The soft tissues of the joint come together to form a joint capsule that can be seen here. Inside this joint capsule is an articular disc and 2 spaces filled with synovial fluid that acts as a lubricant and a shock absorber to allow smooth and hopefully painless movement of the joint. We also have a few ligaments that help to keep the mandible closed and stabilised within the joint. These are the TMJ, the stylomandibular ligament, which attaches to the styloid process and the angle of the mandible. And we have the sphenomandibular ligament, which attaches to the sphenoid bone and the lingula of the mandible. If you need to recap these bones, you can see the previous video in which we looked at the bones of the skull. So let's have a look at the learning objectives we are going to look at today. We are going to look at the locations, attachments and nerve supplies to the muscles of mastication and the digastric muscle, and describe the actions that they have on the mandible. We are also going to look at the structure of the TMJ, and finally the movement of the condylar head within the temporomandibular joint. We're also going to outline the role of the trigeminal nerve, a very important nerve exploited during dentistry. First, let's have a look at the muscles of mastication and their function. And the first muscle we are going to chew on, pardon the pun, is the masseter muscle. The masseter is one of those muscles of mastication we can feel as we clench our jaw. If you place your fingers over the angle of your mandible and clench your teeth, you should feel the masseter engage and disengage as you squeeze your mandible towards your maxilla. Pound for pound, your masseter is the strongest muscle in the body, and if we look at other animals in the animal kingdom, like the crocodile, we can see how effective this muscle is in elevating the mandible. The masseter originates from the zygomatic arch and inserts onto the superficial surface of the ramus of the mandible. That's the surface closest to the skin. When we talk about origins and insertions, we mean slightly different things. The insertion point describes the area that is acted upon when the muscle performs its function. So in this case, the zygomatic arch does not move, but the mandible does. The directions of the fibres mean that when these muscles contract or shorten, the mandible is elevated. This means that the function of the masseter acts to elevate the mandible. The fibres also move in a slightly anterior direction, So the contraction of the masseter also assists in the protrusion of the mandible. When looking at the blood supply and innervation, we have to transect the masseter and look behind, which is what we have done here. This is the mandibular notch, and the space this creates allows for the passage of the neurovascular bundle. The artery that supplies the masseter is the masseteric artery, whilst the masseteric nerve from the mandibular branch of the trigeminal nerve innervates the muscle. On this slide, we have the first of our prosected images, and we can see the location of the masseter just here and here. Let's move on and look at the next muscle of mastication. We are now interested in the temporalis. The temporalis is a large fan-shaped muscle on the side of our head. Again, you can feel this muscle if you place your fingers level with the top of your eyebrows on the very lateral sides of your head and clench your teeth. This muscle originates from the temporal fossa, hence the name, and inserts onto the coronoid region of the mandible. The direction of its fibres means that it acts to elevate the mandible, but it also retracts the mandible because of its posterior fibre direction. The temporalis muscle is innervated by the deep temporal nerves, which is a branch from the mandibular portion of the trigeminal nerve, and the blood supply comes from the deep temporal arteries, from the maxillary after supplying the face. Here we can see the temporalis in situ, having dissected out the zygomatic arch. So we can see the origin from the temporal fossa and the insertion on the coronoid process of the mandible. Let's have a look at what is next. We will now look at the lateral pterygoid muscles. In order to look at the lateral and later medial pterygoid muscles, we first need to revisit the sphenoid bone. So we have the sphenoid bone here, which sits just behind the nasal cavity. We are looking at this from a posterior aspect, so we are looking from the back of the sphenoid bone. We have the lesser wings of the sphenoid here, and the greater wings here. But beneath the greater wings, we also have two pairs of pterygoid plates. We have the medial pterygoid plates here, and the lateral pterygoid plates here. And this is where we derive our names for the lateral and the medial pterygoid muscles. The lateral pterygoid muscle has two parts, an upper head and a lower head. These originate from the lateral side of the lateral plate of the sphenoid and the greater wing of the sphenoid. The lateral pterygoid muscle inserts onto the neck of the condylar process of the mandible, the capsule and the articular disc of the TMJ. The directions of these fibres mean that the role of the lateral pterygoid muscle is to depress the mandible and allow for medial movement for chewing larger items, giving us an advantage of chewing like a cow, providing us with the rotational movement during dinner. The innervation of the lateral pterygoid muscle is provided by the nerve to the lateral pterygoid muscle from the mandibular division of the trigeminal nerve. In this prosection, we can see where the zygomatic arch has been removed, and the ramus of the mandible has also been removed. And this reveals the lateral pterygoid muscle here. So let's have a look at the next of our pterygoid muscles, The medial pterygoid muscle. The medial pterygoid, like the lateral, has two parts. It has an anterior part and a posterior part. Where the masseter muscle attaches to the superficial mandible, the medial pterygoid can be found on the deep surface of the mandible. It originates on the medial surface of the lateral sphenoid plate and the posterior surface of the maxilla, and inserts onto the medial or deep surface of the ramus of the mandible near the angle. The direction of the fibres mean that they act to elevate the mandible when working together. Also, when working together, they act to encourage protrusion. Like with the lateral pterygoids, when each side of the mouth is operated independently, they encourage the side-to-side movements as seen in our lovely cow Clover. The innervation comes from the nerve to the medial pterygoid from the mandibular division of the trigeminal nerve. The cadaveric image allows us to see the medial pterygoid. For the purposes of orientation, this image on the left demonstrates a posterior view of the medial pterygoid. Here is the back of the tongue, and here is where we could find the nasal cavity. The left medial pterygoids have been removed, but we have them available here on the right. On the image on the right, we can see the medial pterygoids in action. We can see the anterior part here attaching to the maxilla and the posterior part here. Both the anterior and the posterior fibres begin to blend and attach onto the deep surface of the mandible. We shall now go and look at the accessory muscle of mastication, the digastric muscle. The digastric muscle is not a muscle of mastication, but it assists with the depression of the mandible, which is why we have included it in this video. Here we have two perspectives of the digastric muscle, the top one being a lateral view and the bottom one being an anterior-inferior view. In this bottom image, we are looking up at the underside of the mandible. This bone here is the hyoid. It's a bone within the neck. And if you're a fan of crime dramas, you'll know that the hyoid bone is a floating bone in the neck that is frequently broken during strangulation. The digastric muscle has two bellies, one anterior belly and one posterior belly. These bellies are continuous and travel through this small loop of connective tissue. It originates on the mastoid process and inserts into the deep part of the anterior mandible called the digastric fossa. Because the hyoid is also a movable bone, the digastric muscle can either elevate the hyoid or depress the mandible, depending on what the rest of the muscles are doing. If the rest of the muscles are fixing the hyoid in place, the mandible will be depressed, which is why we consider the digastric an accessory muscle of mastication. On the final prosection image, we can see the location of the digastric in situ. The posterior belly is here, blending into tendinous fibres before becoming the anterior belly under the mandible. And that has covered our muscles of mastication. So let's recap the learning objectives of this lecture to see what is coming up. So we have covered the first two learning objectives for this session. So now we are going to move forwards and look more closely at the structure of the temporomandibular joint and the movements of the condylar head. When we think about the actions of the TMJ, we have to think about the anatomy in two positions. This picture shows the TMJ when the mandible is elevated. We have partially dissected the zygomatic arch and the condylar head, and therefore we have cut through the joint capsule so that we can see what is inside. The other perspective we need to look at is when the mandible has been depressed. So this image shows the mandible in a depressed state. Here is the zygomatic arch and the condylar head, and here is the joint capsule with the lateral pterygoids in place. When we have these images side by side, we can see that the joint capsule has changed shape, and the condylar process seems to have dislocated from the mandibular fossa. Well, that's because it has, sort of. But before we get into that, let's put some names to this anatomy. This is the articular disc, and this disc allows movement of the mandible. The articular disc separates the superior synovial cavity from the inferior synovial cavity. Both of these cavities are filled with synovial fluid, which acts as a lubricant and a shock absorber to the joint. There are some other regions which we have to know before we can discuss the roles involved with the articulation of the two bones. Up here, on the temporal bone, we have the mandibular fossa. Fossa means impression, so this region here describes the impression in which the mandible sits, or more specifically, the area in which the condylar head sits. Anterior to that, we have a bony growth. In anatomy, we like to call bony growths tubercles. So this bony growth is known as the articular tubercle because it is involved with the articular disc. When the mandible is depressed, when we open our mouths, the condylar process leaves the mandibular fossa and moves forward to allow us to open our mouths wide. This forward displacement has to occur before the rotation of the condylar process can happen. When this happens, the upper part of the lateral pterygoid stretches forward to the articular disc, which then contacts with the articular tubercle, allowing the sliding of the condylar head. When the mandible is elevated, the condylar head retracts back into the mandibular fossa, and the articulating disc goes back with it to aid its movement. In certain circumstances, the articular disc can fail to slide back into place and remain anteriorly. When this happens, patients can complain of clicking or popping sounds due to its close proximity to the external acoustic meatus, accompanied by a degree of pain. This may be the beginning of TMJ dysfunction, which can be debilitating. Additionally, the TMJ can be more vulnerable in certain positions because the condylar process is fairly stable within the mandibular fossa. We know this because it is difficult to move our mandible from side to side when our mandible is elevated. Additionally, we also know that retraction of the mandible is difficult. We only get a little bit of movement backwards. This is because of the shape of the temporal bone directly behind the capsule, but also because we have some incredibly strong ligaments preventing hyperretraction. However, when our mandible is depressed, we can remove the condylar process from its stable home. In the event you receive a blow to the face with your jaw wide open, you run the risk of dislocating the mandible. You could also open yourself up to trouble by trying to open your mouth around a huge burger. But if you overstretch the capabilities and open your mouth too wide, or are hit with a downward force on the mandible, the condylar head can overshoot the target of the articular tubercle and be stuck on the anterior side of the tubercle in a dislocation, leaving you unable to close your mouth until the dislocation has been reduced. Before we round up today's session, we have mentioned so much about the trigeminal nerve, but not what it does or where it goes. Given its role with the muscles of mastication, it would be foolish to skirt around the elephant in the room any longer. The trigeminal nerve can also be called cranial nerve 5, and it has 3 large branches. The ophthalmic nerve, which is known as V1, provides sensory information from the superior region of the face. The maxillary nerve provides sensory information from the middle portion of the face. And finally, the mandibular branch, which provides sensory feedback from the mandibular region of the face, as well as the motor innervation for the muscles of mastication. There is one nerve of the mandibular branch particularly important for dentists, which is this one. This is the inferior alveolar nerve, and it travels through the mandibular foramen before reaching and branching at each tooth to provide sensory information from the mandibular teeth. So let's summarise. We have looked at the muscles of mastication and the digastric muscle and uncovered their attachments and functions. We've also had a good look at the TMJ and explored the movements of the condylar head, before finally we delved briefly into the world of TMJ dysfunction and weaknesses, also addressing the roles of the trigeminal nerve.